You hear me okay? Because I wasn't hearing Nick too well. Oh, that's a little, yeah, I hear a little bit of sound coming out now. Okay, well, I want to welcome you all. I have been in Ukiah for about 28 years. We moved here just about this time of the year 28 years ago. Was it 28 or 20? 28, yeah. My wife Margie is back there, and my wife of 31 years. And our daughter Jessica, our first daughter, was born just about 6 weeks after we moved here. So it was, we've been here all the time, and I don't think we're going anywhere. So I'm very glad to be here. It's been a wonderful place to live. It's been a great place to raise our family. We have enjoyed Ukiah a lot. It's just a wonderful place. So you all are, I grew up in the Midwest. When people complain about the weather around here, I just kind of shake my head. You from the Midwest, you know, yes, you know about what, yeah. Okay. I just shake my head. I just, yeah, it's hot. Yeah, it's hot. Or, yeah, it's raining, but I'll tell you what, it's pretty nice here. I want to talk to you tonight about what I call the big three diseases that affect our older population, our aging population. We are an aging population. I often say this to people that, you know, well, our healthcare system is not perfect. It's got problems, right? Everybody recognizes that. But I will tell you something. When I moved here 28 years ago, I would see people in their 90s, yeah, you know, once in a while, a couple times a month maybe. I see them all the time. All the time I see people in their 90s. I've got a few people in their hundreds. So one thing we're doing right is people are living longer. You know, maybe they're not always living longer in a real productive or good way. We'll try to address that a little bit, how you can do that. But I think today's 80, you know, used to be kind of the 65 or so of about 20 or 25 years ago. That's my impression anyway. So I want to talk to you a little bit about three eye diseases that are very common and that afflict a lot of us as we get up in years. So Eyes and Aging is the title of the talk. And to start with, I want to do just a little tutorial on how the eye works. So how the eye as the end organ of vision works. So you've got a cross-section view of an eye here. Okay, it's a hollow ball that's filled with a kind of a jelly or semi-jelly in the center. And it's got two focusing elements. The cornea, which provides about 75% of the focusing power, and then the lens, which provides about 25% of the focusing power. So light rays, think of your schematic diagrams that you've all seen, light rays coming in straight, they're bent. They're bent because of that curved surface. That's what makes a lens a lens. And the cornea is a lens like the iris, but it's a lens that actually does more focusing than the lens of the eye. So the light rays are bent mainly at the air-tear interface on the cornea. They're bent a little bit more as they go through the posterior cornea, and then they go through the lens and they're bent even more. And then they come to a focal point, like a pencil point, in the center back of the eye. Now, think about everything we see is upside down and backwards. Did you realize that? The inside of the eye is lined with the retina, and the retina is this incredible light-sensitive layer of tissue which converts the light rays into a neural impulse. The neural impulse then goes on back at a pretty basic level through the optic nerve, and it goes to the brain where there's a couple of synapses, and then it goes to the occipital cortex. So the actual seat of visual perception is in this part of the brain back here. Now everything in the eye is upside down and backwards. Think about it. If I wanted to look out of that door over there and I wanted to look to that side, I would stand over here, right? If I wanted to look to the other side, I'd have to go to the very back of the room. Well, that's just the way the eye is. So you can see that light rays, they're not going to bend like that. They're going to bend a little bit, but light rays coming from this direction are still going to end up over in this part of the eye. That's why everything in the eye is actually upside down and backwards. Your brain actually turns it around so that when you have this thing, this marvelous God-given thing we call perception, visual perception, everything's the way it should be. So in a healthy eye, you've got, it's like a camera too. That's another thing that we can kind of use as an analogy. The iris is kind of a muscular and pigmented diaphragm. It's like the diaphragm or this aperture stop on a camera. So that I didn't talk about. And this just reiterates what I said about the retina converting those light rays into a neural impulse. So the retina is a very complicated tissue. It's made of lots of layers that are carefully organized into this very finely developed thing. The photoreceptors, you've all heard of rods and cones, right? Rods and cones are, if we were to look again, I'm trying to go backwards. Does this thing go backwards? Maybe it doesn't. Now I'm getting a blank screen. Well, I guess it doesn't go backwards. So the macula is the center part of the retina that allows you to see fine details clearly. So you're looking at somebody's face, recognizing face, reading, looking at street signs. When you are looking at something, an image of that something, that object that you're looking at, is being formed in the macula. The peripheral retina is very important too. It's important for side vision, for being aware of your surroundings, helps you to see something off to the side. But if you were to look at an eye chart, you would be able to notice right away that if you look just a little bit off line, you can't tell what you're looking at. Just like if you look a little bit off of somebody's face, you probably wouldn't be able to tell exactly who it is. So this is a photograph of a normal retina. There's the optic disc or optic nerve head. You can see naked vessels lying on the retina. This dark area is called the macula, which I think is maybe Latin for spot. So it's kind of a dark spot where the cones are concentrated, the cones of rods and cones, and it's important for color vision. The form or the rough vision of peripheral vision is important too. Like I said, it helps you to walk and navigate. So there's two definitions of blindness. One is that you have to have 2200 best corrected in the better eye. That's for the central vision. But another definition of blindness is that your visual field is limited, peripheral vision, to 10 degrees within center or fixation. So when you look straight ahead, you draw a circle around that's 10 degrees. That's, you got to have more than that. If you only have 10 degrees, that's legally blind. Because it really limits your ability to get around to have that, even if you can see small print and so on. You'll see that one of these diseases, the one we're going to talk about first, age-related macular degeneration, it really affects the central or fine vision. There is a layer underneath the rods and cones which support the health of the rods and cones called the pigment epithelium that is the main thing that is damaged in macular degeneration. And when the pigment epithelium is damaged, then the rods and cones and all the rest of the retina gets damaged too. People don't go totally blind from macular degeneration. Mainly they lose their central vision. But that's debilitating because you can't pass a driver's vision test or read normal size print. So it's the leading cause, probably the leading cause of significant vision loss in people over 65. It is definitely associated with aging. There are some things that look like macular degeneration that occur in younger people, but they are not near as common. I know that probably some of you may have questions. Maybe I'll take a few minutes after each of these main parts here to answer some questions about each part. So maybe that would be the best thing rather than to wait until the very end so that you don't forget your questions. So early macular degeneration, or AMD, you may hardly notice it. Oh, I pushed the wrong button. You may hardly notice it, and it may just be like maybe a little bit of waviness of, say, a straight line, a telephone line or something. But when it gets worse, there will be a significant area missing in the center of your vision. Straight lines may be much more distorted. And that's when people really, are in a bad way. There are two major forms, wet and dry. Atrophic or dry is more common, and we still do not have a very good treatment for the dry form. Wet or exudative macular degeneration is less common, tends to be more abrupt in its onset, tends to be a little bit more severe, but both of them are potentially blinding. So let's look a minute at the dry macular degeneration. So there's things called drusen, which are little, drusen is a plural word, it's a German word, so it's, Druse is actually the singular, drusen is more than one. Thinning of macular tissues. The drusen are little yellow dots. If I push the correct button, I think you can kind of see them here. They're these little pale yellow dots that are clustered in the back of the eye. They can sometimes occur in other parts of the retina too, but in macular degeneration, getting drusen usually involves getting them in the macula. The vision loss is most often it's gradual. It's more common, as I said. Now, the wet form of macular degeneration is caused when there are breaks in the tissues that are under the retina, between the retina and the pigment epithelium, or between actually the pigment epithelium and the underlying vascular layer called the choroid. So the vessels leak fluid. The fluid causes the retina to bulge sometimes or to thicken, and it separates the sensory retina from the pigment epithelium, and then the retina gets badly damaged because it really needs that pigment epithelium as its support tissue to keep healthy. Vision loss tends to be a little bit more rapid, a little bit more severe, and this, though, is something that can be treated. There has been a breakthrough in the last several years on wet macular degeneration that we'll talk about. So how do you diagnose this? It's it's often asymmetric, so one eye can be affected worse than the other. I've had a number of times people come in and say, I suddenly lost my vision in this eye. Well, what they really had happened was they covered their other eye and suddenly noticed that the vision was gone. That happens more often than you would think. Because we have two eyes and we keep them all, we keep both eyes open, people often don't realize how one eye has dropped off. So the ophthalmologist can detect macular degeneration or early changes like drusen during the exam. That includes looking in with an ophthalmoscope and also fluorescein angiogram. Fluorescein angiogram is a test that used to be done here, but it isn't now. I send people to Santa Rosa if I feel that they need a fluorescein angiogram, and I send them generally when they have, especially the wet form of macular degeneration. So what is a fluorescein? It's dye injected into the arm. It goes into through the circulation, then gets into the eye, and there is a special camera that has special lights that excite the dye, and then the dye actually fluoresces or glows, and they take pictures. And the dye has a characteristic of staying in intact vessels, but it leaks out of damaged or new vessels. So when, and also when there's breaks or what we call window defects in the retina, you can actually see the dye lighting up through areas that you don't normally see it. And that can highlight where the blood vessel growth is and where treatment should be directed. Now, there's really no treatment for dry macular degeneration. Like I said, this has been a challenge for many years that we have tried to, tried to get around. Nutritional supplements may slow the progression, and this, I just changed this slide today because the old study called AREDS, which was done, I think it was released in about 2004, the first formula they used was vitamin C and E, beta carotene, and zinc. Beta carotene is the stuff that makes carrots orange, but lutein and zeaxanthin are similar compounds. They're plant-based compounds, but they're found in a little greater amounts in things like spinach and kale. They have found that with beta carotene, there is a significant drawback. Beta carotene causes an increased risk of lung cancer in people who smoke or people who were smokers. So if you were a smoker, have a significant smoking history, you should not take beta carotene because your risk of lung cancer actually is worse. So we don't want to do, we used to have these supplements, there was an AREDS formula, and then there was an AREDS smokers formula. And the smokers formula was a little different because it didn't have lutein in it. Well, the new study that was just advanced on the 2004 study showed that lutein and zeaxanthin are actually a good substitute for beta carotene. So if you, I think that you're going to start seeing more of the supplements now containing lutein and zeaxanthin rather than beta carotene. Beta carotene, by the way, the body changes into vitamin A. It's a little bit safer, even if you're a non-smoker, to take beta carotene than vitamin A. Vitamin A, you can get toxic dose if you take too much vitamin A. So they're not cures, they can't restore vision, but what they do is they just make your chances a little bit better. If you have early macular degeneration, they make your chances of getting a progression of the disease better. And it's probably based on, some people get better and some people will progress. It depends probably upon your genotype, what kind of genes you carry on your chromosomes. There's probably 15 or 16 genes that have to do with the development of macular degeneration. It's not a simple thing like sickle cell disease or color blindness. So,
you just have to let yourself go blind, basically?
No, you should take the supplements, but I think you should also know that and this is something that I preach to my patients all the time. We have a very reductionist mentality. We want to take beta carotene out of carrots, right? Lycopene out of tomatoes and lutein out of spinach and put it in a pill and say, here, take this pill. It makes sense that you're better off taking whole food, okay? Eating of whole food. If you want to do a supplement, fine. If all you eat is TV dinners and Burger King, yeah, you better take the supplements. But you are really better off if you eat a whole food. And whole foods that contain especially lots of antioxidants, blueberries, pomegranates, things like that. Even green tea and chocolate has antioxidants. So there's some really good things that have antioxidants, but you got to get a wide variety. Now, the treatment of wet macular degeneration is the breakthrough that I've talked about. We now have this anti-VEGF treatment. VEGF stands for vascular endothelial growth factor, and this is elaborated by abnormal vessels or by the retina to grow abnormal vessels. when macular degeneration is occurring. It also happens in diabetic retinopathy. When new blood vessels form abnormal blood vessels in the retina, it's because of VEGF. By the way, this is also a factor in tumor development. And these drugs were actually originally developed because somebody had a brainwave. When a tumor forms, it must have a blood supply. What is making that blood supply develop? Well, they researched and found out that it's this stuff called vascular endothelial growth factor that your body makes, the tumor makes it. So they developed these drugs originally to treat colon cancer, and they are still used. Avastin or bevacizumab is still used as a mainstay of treatment in colon cancer. What it does is it blocks the development of new blood vessels. And so when those new blood vessels don't get going, they wither, then the tumor withers. So, and VEGF has, like I said, it's a factor in diabetes, so it's becoming much more common to use these drugs to treat diabetic retinopathy. How do they work? Well, they're injected with a very fine needle in your eye. That's a scary thought, isn't it? It's done, and I send people down to the retina specialist for this. Probably, general ophthalmologists can do it sometimes, but I tend to prefer to let retina specialists treat this. There is some different factors now. Avastin is the one I was talking about. It's a very cheap one. There are some very expensive ones that are used also. In fact, a brand new one called Eylea, which it's a anti-VEGF drug that lasts longer. The main drawback with these drugs is you do an injection, and about a month or two later you have to do another injection. You have to keep doing these injections. And so they're finding different little modifications of these drugs that will exert their effect for a longer time. There's a small risk of complications with this treatment. But I'll tell you, I've seen a lot of great successes with the people that I've sent down to the vitreoretinal group for VEGF injections. Yes, sir?
In the frame before last, you said there was a certain chemical in the body that causes the blood vessels to rupture. What causes this chemical to be present in the body?
It's elaborated by cells in the tissues, in the target tissues, in the retina, or in the tumor that's growing. It's a hormone-like substance that is elaborated by these cells, which stimulates the growth of the vessels.
What causes that to happen?
It's what a tumor needs to survive. It's how retinopathy, the retina. How it happens in retinopathy, in diabetic retinopathy, let's say, the retina is starved for blood. It's an extremely active tissue. Its blood demand is very, very high. And so in diabetes, the tissue gets starved for oxygen because the circulation gets affected. And so the retinal cells will secrete this stuff. Let's have more vessels coming in. We need more vessels. We need more oxygen. So it's kind of it sounds like a self-correcting mechanism, but the vessels that are elaborated are not normal. They break and bleed easily, and it's the same thing that happens in macular degeneration.
So a metabolic disorder like diabetes or whatever causes that?
Yes, yes. So sometimes anti-VEGF treatments are combined with other therapies. Photodynamic laser therapy is hardly ever done anymore. There have been a number of things tried for various types of macular degeneration. Some of them work a little bit. They've tried proton down at Loma Linda. They've tried plaque treatment, like little radiation emitting plaques. Nothing has been quite as good as these new drugs that we call anti-VEGF drugs. So when it can't be treated, you don't become totally blind. You will retain your side vision. With low vision rehab, we can help people that have lost central vision to get around that blind spot. Sometimes You know, there's special magnifying lenses, magnifying glass, simple magnifying glass can help. Sometimes you know, a big screen with a closed circuit camera can magnify print so that a person with a big blind spot can read by passing it, you know, under that camera. There's lots of little electronic devices now, and there's even some, you know, experimentation with these little arrays that can be put in the back of the eye, which will give, you know, a little bit of form vision, but it's a long ways from being anything like what we were given by God with the natural mechanism that we have to see. So skills, devices, techniques, they can help people live a little bit more normal life and a little more independently despite the loss of central vision. So there's several people that can kind of collaborate. I will often send people to Dr. Gilbreth in town who has a real interest in low vision evaluations and helping people get low vision devices. Occupational therapists, you know, there's a list here that gives you all the people that can kind of help if you lose vision from, you lose the central vision. Yes, ma'am?
Does the side vision remain with both the dry and the wet?
Yes.
Okay.
Yeah. So like I said, you can use different magnifiers, telescopes, etc. Some people even drive using these telescopic, you know, special telescopic glasses. So large print books, writing, signing guides, you know, large face watches, playing cards, you name it. There's all kinds of things that you can help that are non-optical helps. So you have to check your vision. I don't usually have people check it every day. That seems like a little bit overkill, but you know, that's what it says here. Check your vision every day with an Amster grid. If you don't have macular degeneration, probably once a week or once a month is not a bad idea. So this is a normal Amster grid. This is what an Amster grid may look like in an area that's affected. It's a little off center. Usually it's going to be right in the center. This would be a more accurate slide, I think, if it had this little wavy area right up in here, because that's where it usually affects people. So regular eye exams, good idea. How does it preserve?
How does a regular eye exam preserve vision?
Well, by detecting problems earlier, especially problems like cataracts and glaucoma, which we're going to talk about now. Macular degeneration, if you get the wet form early, yes, you can get much better preservation of vision, absolutely. The dry form, there just isn't much we can do for the dry form. Yes,
So
sir.
with wet and dry macular degeneration, they both appear to come from changes to part of the eye.
There are aging changes in the central retina.
Does that mean that from the time you wake up till you go to bed, it's going to be kind of the same? You're not going to be worse when you're tired, or it's going to be pretty much a constant state because it was a change to part of the structure of the eye.
Yes.
So anything that has changes during the day, whether you're tired or if you use it a lot, isn't going to be macular degeneration.
Probably. I would say that that's probably accurate, yeah. Tiredness can be multiple factors. Dry eyes are a real common problem in older folks, especially in women. And dry eye is probably something that would cause more fluctuation, or meibomian gland dysfunction, which is incredibly common. You know, and it's a kind of a form of dry eye. And it may cause your vision to fluctuate over minutes or hours, or even blinking, you know, can kind of temporarily clear your vision. So if you have something that's happening like that, it's probably one of those things rather than macular degeneration or cataracts or glaucoma. So let's go
I'll
on.
ask you one more question.
Yes, sir.
That doesn't necessarily occur to both eyes at the same time, right? So
Not necessarily, but there can be,
is it
they
more
can
likely
be
to
very
occur to the second
asymmetrical.
eye if you have the first eye?
Yes,
Okay.
but they can be very asymmetrical. So it can definitely affect one eye much worse than the other.
What percentage about of people over 65 would be getting this in our society?
Oh, that's a good question. I'm not sure. I would probably say 10 to 15%, or maybe even higher. The longer you live, the greater your risk. And that's true for glaucoma, and that's true for cataracts. So we don't really need to talk about the healthy eye again. We did that. Let's talk a little bit about cataracts. Cataracts are the clouding of the lens part of the eye. So here's a healthy lens. It's not perfectly clear. When you shine a light into it, the light will get scattered a little bit. But in a lens with it, but it's pretty clear. It's clear enough that looking into a healthy eye with a normal lens is like looking through a window. It really is amazing, and I am just always in awe of the privilege that I have of looking at the back of people's eyes. It's really quite beautiful, and it's really something to see, and it's just something I see every day. I kind of take it for granted, but it still inspires me with a little bit of awe. So a cataractus lens, now there are different types of cataracts. This is not a very good drawing because really a kind of a yellow-brown lens like that, it's what we call a nuclear cataract, so it's really in the center part. The outer part, the lens is like an onion, and it's continually added to throughout life. The outermost parts of the lens are the most recently laid down. And so you all know that when you get into your 40s, maybe for some of you into your 50s, what happens? Your arms get too short, right? Yeah, that aging change that we all experience when we get into that age. So, oh my goodness, I just totally, can we back this up? Can't back it up, honey.
Hit the back. There you go.
Oh, okay. Okay, yeah, we did get, okay, so I guess we do have, yeah, we can back it up. So it's a continuation of the process that causes us to feel like our arms are too short, okay? The lens is changing, and most of the time it changes from the inside and causes this hardening of the innermost part of the lens. Sometimes the changes will take place as kind of a feathery graying of the outer part, what we call the cortex. So you can see that this picture shows, well, this shows it too. I guess that's the nucleus right there, probably. This picture shows it too. There's different little bands of, kind of zones that it's showing. And that's how the lens is, how the lens is built. So it's not, what is a cataract? There is a picture of the clear lens showing that that's our typical schematic diagram of the light rays. They're being bent, they're being focused like a pencil point. The light rays are more scattered with a cataract. They don't get bent right, they get blocked or distorted. A cataract is not a film. It's not caused by overuse. It's not catching, and it's not does not cause irreversible vision loss. It's painless. They're painless blurring of vision. There's no discomfort or pain associated with a cataract except maybe just a feeling of tiredness or strain from not being able to see things and from working hard. So glare, light sensitivity, poor night vision. Driving at night is a big one. That's a huge one that brings people in to actually and has them make that decision to go ahead and have cataract surgery. Sometimes double vision or like a ghosting is a sign of a cataract. Not a sign, a symptom of a cataract. A sign is a thing that the doctor sees. A symptom is a thing that the patient tells the doctor. Needing brighter light to read, fading or yellowing of colors. You've seen maybe discussions of certain artists who, when they aged, they used more and more garish pigments. You ever heard of that? I think maybe Monet was one of them. He used more and more, bright pigments in his paintings because his cataracts were filtering out all that, color. So anyway, he knew that if he, for his perception, it was just not right. So what causes it? Too many trips around the sun is what I like to say. aging. Family history is a factor. Lots of times when, and man, I'm getting to the age now where I'm doing cataracts in people younger than me. It's pretty sobering. So if you have a family history of people getting a cataract at a young age, you're more likely to have it happen to you. And it's often the case if I do somebody with a cataract that's in their 40s or 50s or sometimes even their 30s, they had a parent that had the same thing. Injury can cause cataracts, sometimes electric shock, ionizing radiation, blunt injury, penetrating injury. Steroids are pretty significant cause of cataracts, believe it or not. If you're on chronic steroids, you have a greater risk of cataracts. Long-term unprotected exposure to the sunlight. We see cataracts, I think, a little bit more in people that are outdoors a lot or maybe live at high altitudes. Previous eye surgery is also a risk factor for cataracts. Yes, ma'am?
Do sunglasses help that?
Well, if you wear sunglasses consistently over many years, probably. You know, your cornea filters out, I think, about 90, I forget the exact figure, but I think it's 97, 98% of ultraviolet light. Blue light may be a little damaging too. The corneas don't filter that out so much. There was another question. Yes, ma'am?
Yeah, regarding sunglasses, what are the best kind of sunglasses? Because I'm finding if they're too dark, I can't see. But a little.
Oh boy, that's probably beyond the scope of what I can even tell you. You can spend a lot of money on sunglasses. I didn't bring them with me, but I've got some that are, Ray-Bans that they're pricey. And you can go to the gas station and get probably, $5 or $10 pair that probably filter out UVA and B, and that's all you really need.
So you should look for that.
Yeah. I would say, yeah, look at what it says it filters out. If it filters out most of the UVA and B, that's probably adequate. Yes, sir.
So that, you're saying that's more important maybe than the tinting of a sunglass?
Well, tinting, there are different tints that work for different things. Yellow tint is useful for contrast in fog. Hunters will often use yellow glasses, especially if you're a duck hunter or something like that. You're out on, in foggy terrain. Brown is probably the commonest color. I don't know that other than that it makes a big difference, but I'm not an optician, so I don't think I can really give a...
But as far as affecting or producing cataracts...
The main thing is you just want to filter out, the main thing you want to filter out is ultraviolet light. And like I say, your cornea really filters most of that out. There was a hand back here, and then, yeah.
Is it possible over time that if your head's low enough that you can actually have a regression in the size of the cataract? You can actually get smaller?
A regression of size?
Yeah.
Now, once it gets going, it's not really possible. There are no drops, there's no drugs, there's no vitamins that can actually shrink them. I have seen some things that say, oh, what was it that I saw recently? It was a naturopathic remedy. Was it castor oil? It was something weird, And they said this caused symptoms to become better. I think it was castor oil, but I don't think it works, I don't think any cataracts is, one of the ARED's goals, one of the ARED study that I mentioned about macular degeneration, it was also looking at cataracts. This study is AREDS, which means age-related eye disease study, AREDS, okay? The questions that they were asking was, do any of these supplements by themselves or in combination slow down or reverse macular degeneration or cataracts? And they found that on the ARED study that they had no effect whatsoever on cataracts, 0. By the way, the new ARED study, I forgot to mention, they looked at fish oil, omega-3s, and omega-3s were not found to be helpful for macular degeneration. It's a little surprising to me because I recommend fish oil or flaxseed oil to patients a lot, but they are not helpful in preventing macular degeneration. Yes, ma'am, you had a question.
What's the difference between UVA and UV, is it UVB?
Yeah, one's a shorter, higher energy wavelength. A is, I don't know the exact number of nanometers or whatever the measuring, the unit of measurement is, but visible light falls in a fairly narrow band. It's green is 530, something like that, 530 nanometers. Red is maybe 700, 800. So the longer the wavelength, the lower energy the light. The shorter the wavelength, the higher energy. Yes, Steve.
Tell us about cataract surgery. How does that alleviate the condition?
Well, we'll get to that. There is.
Question before we go on.
Yes, sir.
Okay, related to this list right here, as I'm looking at this, how much is this your eye trying to respond to irritation? We have injury to the eye, medication, steroids are going to be making things try and grow and heal. Long-term exposure to sunlight, your eye's trying to heal. Previous eye surgery, your eye's trying to heal.
Mm-hmm.
So how much is this, aging, your eye's trying to maybe going out of control and how it's trying to heal? Is that what's actually happening here? Because like diabetes, when you talked about it in relation to macular degeneration, it was trying to pull more blood vessels.
Yeah. It's not quite that way because the lens is completely without blood vessels.
Okay.
I'll tell you what I think it is. And the analogy I often use is think of an egg white. It's clear, right? You drop it on a hot skillet, what happens? It turns white, okay? The same thing is happening in the lens of the eye, and it's to the same types of molecules. They're proteins. There are proteins that are isolated and they are changing. The proteins are being slowly denatured. They're being cross-linked, and there are chemical changes that are happening to these special proteins called crystallins that are isolated in the center part of the lens from the time you're in the uterus, so when the time you're starting to develop as an embryo or a fetus. And then they get constantly added to slowly. So it's not quite the same. I think it's an alteration of the proteins that's happening. Yes, ma'am.
So if you have a history in your family of your grandparents and your parents having cataracts, and you have been told that you have cataracts, but they haven't reached this whatever magical place for you to have cataract operations, why would you not take one as you're younger, healthier, have those cataracts removed rather than wait until you're in your 80s?
Good question. It's a risk-benefit ratio. And also, the young lens is, remember, it focuses, it changes. Maybe I didn't explain that. But the cornea doesn't change its shape. The cornea, I said, does 75% of the focusing. The lens does about 25%. But the thing that's cool about the lens is that 25% is variable. When you're young, when you're a little kid, if you have children and they say, "Mommy, look at this," and they push something in your face, kids can focus like this. They can focus things right up to their noses almost because their lenses are so soft and flexible. So you have to really weigh the question as a risk to benefit proposition. Okay? What's the risk of doing the surgery? What's the benefit? What's the risk of not doing the surgery versus the benefit? Okay? So that's what it is. And for a person that is sedentary, that doesn't drive, or doesn't drive at night, or has a very, low demand, visual demands, they'll keep their cataracts for much longer. I did a lady today that she said, "Yeah, I have no complaints." Her vision was 20/60 or 70. She had just terribly hard cataracts. I mean, they were incredibly hard. And it's very common when I do surgery in a person like, say that has a 20/40 cataract in one eye and a 20/70 in the other eye, they say, "This eye is really bad, but this one's good." And then we do the 20/70 cataract and they go, "This eye is really bad." That happens a lot. Yes, ma'am.
Well, her question was kind of my main question why I came tonight is I can't stand light, like this light here bothers me a lot, and I can't do through the night driving, and I've been diagnosed to have tiny cataracts. But I've been, like the last 2 years, they say, oh, they're too tiny, we can't operate until they get bigger. And I go, well, how do I know? You'll know. Well, how am I going to know? And how many years more?
Well, you can get a second opinion if somebody's reluctant. Maybe you're going to an optometrist that doesn't do cataract surgery. They're going to an ophthalmologist. Well, maybe they're just.
No, but I mean.
We look at cataracts and we say.
They're really tiny.
Mm-hmm.
But, yeah.
We look at them and we will kind of make a guess. How bad is this cataract affecting the vision? We'll look through the cataract. And
Are there other things that could clearly be making the problem with the light and the night driving?
possibly. Could be dry eye. Could be your tear film is breaking down. So those would be other things that should be, at least looked at. Yes.
One last.
Yes, sir.
Is shingles one of the other possible causes for cataracts?
In the sense that, yes, possibly, because shingles can cause inflammation, and anything in the eye that causes inflammation can cause cataracts. So the short answer is yes. Usually we don't think of shingles as causing enough inflammation. We usually shingles is pretty easy to diagnose. I mean, you can look, a layperson can look at and shingles often affects this area, It's like, I think 20% of shingles cases are in this area. So they can affect the eye. They're terrible, miserable disease. Yes, you've had it, huh?
Yes.
Yeah. So how quickly does a cataract develop? Sometimes it's very gradual and over years, and that underscores my point about a person with like I did cataract surgery on today, who had 20/60, 20/70 vision, but had really no idea that she had the cataracts. I mean, they had happened so slowly that she wasn't aware. So anyway, they usually take years. Non-age-related age-related cataracts, especially ones that are familial or ones that are in people with diabetes, they often happen quicker. The steroid-related ones, they're often what we call a posterior subcapsular. They can happen fast. They can happen over weeks, even maybe less than weeks, where they really start to bother a person. So it varies between individuals, of course, and even different between the two eyes. So progression may be protected or slowed a little bit by UV protecting glasses. Okay, so surgery is the only way to treat cataracts, I would say. Not just, it's the only way to remove them. If they're not affecting your normal activities, then we don't recommend surgery. If they're, maybe sometimes the lens change will cause a change in the eyeglass prescription. So you can get your glasses changed and be good for maybe a year, maybe 6 months. It's hard to know. You can't predict. So when they affect your ability to do your job, to drive, to read and watch TV, you have to make that decision along with your eye doctor. I would certainly ask whoever's seeing you, you who asked the question about, they say the cataracts are really small. Well, is there something else? Is there something else that's maybe contributing to my complaint here of whatever the problem with your vision is? So it's generally an outpatient procedure. It's almost always done under local or topical anesthesia. We can do it with you asleep, but there's a little bit of risk of putting you under general anesthesia.
Excuse me, when you say risk, to value, that's what we're talking about here.
Mm-hmm.
You always, all the doctors mention the risk, but they don't say anything about what the risk is and how much it is or any of that sort of thing. What's the risk of blindness? Is it of
Well, there's no really risk
infection?
there is a risk of infection. It's very, very small though, probably about 1 in 1,000.
So it sounds like there's not
Infection is bad though if it happens. If the inside of the eye does not have good defenses against a bacterial infection, it's a serious thing if you get a bacterial infection after the cataract surgery. The other risks of surgery are the cornea can be damaged. Sometimes a retina detachment can occur following problems with complications of cataract surgery. So there are certainly risks. The great majority of people that have cataract surgery, though, do well and are quite happy with the result. So, true or false? Cataract surgery is done with a laser? How many say true? Some people say true. How many say false? Not many people are saying false. One. Okay. Yeah, this is very common misunderstanding. However, that's changing. Lasers are now being developed to do some parts of the cataract surgery that are most difficult, shall we say, or critical to do right in cataract surgery. One of the steps that's critical is making the circular opening in the lens capsule. There is a laser now that will do that. It will actually cut a circular opening in the lens capsule. That laser will also cut the incision, which can be a source of problems if it's not done just so with cataract surgery. Very, very hard cataracts can be a big problem. They are much more difficult to do. And this laser can actually soften up those really, really hard cataracts. These lasers cost somewhere around $1 million, you know? I mean, I don't know who's going to pay for this, because when these lasers are used, the insurance companies are not reimbursing extra for the use of these lasers. So I don't know where it's going to go. People are saying, oh, the laser is the way of the future. And probably it is, but the economics of it have me concerned.
There's a lot less labor involved, though, with laser surgery, I would think.
Not much less. It probably still takes, usually surgery takes about between 10 and 15 minutes. And so even with, just manually doing the cataract, it's not going to take a lot shorter than that if you have the laser. You got to dock the laser, you got to aim it, focus it. All those things take a little time. So
When you say hard and soft, is a hard one an older one?
usually so, yes. That is usually the case. The older a person is when they have the lens removed, the harder it is usually going to be. Remember, it's a continuous process from childhood on through middle life to old age. Yes, ma'am.
Is it normal that at night, driving after you've had cataract surgery, that the lights of approaching cars beam out and bother you?
No, usually night driving is better. It's usually helped by cataract surgery. You could have perhaps an after cataract. That is a clouding of the lens capsule, which the lens is put inside of.
Can you do something about the...
You can laser a hole in the lens capsule. And that's a very quick and simple thing, and we do have that laser here. That's not an expensive laser. So that's a quick, easy solution to an after cataract. I think there is a slide that shows that. Yes, sir.
When you're doing this surgery,
Mm-hmm.
is it a visual judgment on what constitutes the cloudy material that you're removing? As someone who's done many types of work in my life, it's always concerning to me, all right, how is this decision made on which material to remove? So that, okay, let's get all the cloudy material. What constitutes cloudy material?
Well, no, you're removing the whole lens except for that little bit of capsule. You're removing the front part of the capsule and you're leaving the rest of the capsule. So you're taking everything out, whether it's a nuclear cataract or a posterior subcapsular cataract, whether, even if the cataract is just along the very back, as in a posterior subcapsular, you have to take the lens in front out.
So
You can't.
Just a capsule now.
So there's a what we call the capsular bag is left, and we put inside that bag the lens implant.
Okay.
Yes. And that's a picture. This is a picture of the lens implant. It is fitted to the size and shape of your eye. There are two main factors: how big your eye is front to back, and the curvature of the front, that determine what power of lens implant. Lens implant powers range from 6 to 30 plus. So there's a big range in eye sizes and shapes, just like there's a big range in people, shoe sizes or height. Any kind of thing you measure in a person. The lens implant or IOL is usually placed in the capsular bag. Sometimes it's placed in front of the iris. We prefer to place it in the natural place where the natural lens of the eye was. If we have problems during surgery, sometimes we have to put a lens implant in front of the iris. But the great majority of the time, we're putting it in the capsular bag. Most of the surgeries are done without complications and result in very, very rapid and immediate and gratifying improvement in vision. You get in, you put in drops for a few weeks. There's steroid drops that you use. Steroids don't bring the cataract back. Lens is gone, so you don't have to worry about that, but the steroids do suppress inflammation. There are also, yes ma'am?
The word most, at the very start of it.
Most. Quantify that. 96%. 96, 97%. 95 to 97, I'd say, are done without. Really, that's really pretty. That's pretty good. It's pretty good odds. So you may need an eyeglass prescription to correct astigmatism. There are astigmatism-correcting lens implants. There are even lens implants now that will correct for not only distance, but for close-up. They're called multifocal lens implants. And these lens implants, about 2005, I think the government made a rule change that allows us to put these, what we call premium or special technology implants in for an additional price that's not covered by insurance, like Medicare. Okay? Nothing is perfect, though. There's even accommodating implants that shift their position a little bit. None of them are quite the same as the natural lens of the eye, but they're pretty good. They're pretty good. Yes, sir.
So you were talking before about how our lenses get thicker as we get older, less flexible,
Yes.
changes your ability to focus.
Harder.
Okay, so now I'm putting one of these in. I've taken the center of the lens out. I assume this is mostly one position.
Yes.
So I've made a choice now. I'm either going to
Yes.
focus out there or I'm going to focus here, depending on what lens you just put in my eye.
That's right.
So that's a choice that has to be made. So now when you're talking about this multi-focus lens, does that mean that the muscles of my eye are changing its surface, or they just have?
That's an accommodative.
That's what I meant.
That's an accommodative implant. Some accommodative implants have little hinges on them. Some of them actually, none that hasn't been approved yet in the US, but some that have actually a 2-lens system that goes in the capsular bag. And the ciliary muscle that works the capsule, it's still working. It's still there, even in an old person. So that mechanism still works. If you can get those, if you can design something, let's say you could make a tiny little opening in the lens capsule, get all the lens material out, and then fill it with a resin or a polymer that would then gel, okay? It would form a nice soft thing. That's kind of the end goal of what we're trying to do. We have not got there yet. We have not got there. But there are these accommodative ones, and then there's multifocal ones, and the multifocal ones work by different designs. Now, I am at an hour, and so we're out of time. I will continue to go if you want me to go.
Yeah.
Okay, yes, ma'am.
Okay, so can you have one lens for reading and one lens for distance?
Yes, that's called monovision. And if you had, let's say you're a nearsighted person, okay, and you've been nearsighted from childhood, okay, and let's say you've worn contact lenses, okay, and you've worn contact lenses that are about, say, -4, -5, something like that. You're -4, -5 nearsighted. And so what you do is one eye is undercorrected, so one eye is focusing up close, and the other eye is corrected for distance. So that one's focusing in the distance. Sounds really yeah, it sounds weird to a person that's never done it, but believe it or not, about 2/3 of you would adapt to that. About 1/3 do not adapt to monovision.
So if you had, you know.
So before you continue, yes, you could do that as a strategy for cataract surgery in a person that did that and knows that they're good with monovision.
With contact lenses.
Yes.
You could do it with contact.
If you did it with contacts, you can do it with implants. Yes, ma'am. Yes. Yes. Would you like me to address dry eye? It was not one of the subjects of my talk. Let me go through, finish this, and if you want, I'll do a little bit. I could talk to you later. Dry eye is extremely common, much more common in women, underdiagnosed, undertreated. There are lots of kind of a stepwise treatments for it. It's a big subject, and it's not just the inability to secrete tears. It's a complicated subject, but it is common in women. It's more common in postmenopausal women, and it's a common thing. And it can be really bad. It can be just debilitating if it's really severe. Okay, so here's where we're talking about the laser use. The supporting capsule becomes cloudy, and then posterior capsulotomy using the laser. Man, I've got a lot of this talk left. Probably 1.4 to 1.5 million people a year have cataract surgery. It's one of the commonest surgeries performed in the US. There you go. It says 95% cataract surgeries are performed with no complications and improved vision. So, okay, let's talk for a minute about glaucoma. We already did our little tutorial on the eye. So, glaucoma is a disease of the optic nerve. It is damage to the nerve which causes loss of vision. A blind spot develops usually in the nasal side of the vision. So, and I've seen cases where glaucoma was really far along before it was recognized. Very sad, because it's preventable. It is one of the leading causes of blindness in the world. Probably, I think, number 2 after cataracts, cause of blindness in the world, worldwide blindness. It's more common in people of African descent. It's more common in people of Hispanic descent. I think it's a little more common in Native Americans. It's certain forms of glaucoma are more common in Asians. But it happens in us regular old white people too. So clear liquid called aqueous humor circulate, and it's common. It's common. So, and the older you get, the greater the risk, like these other things. Clear liquid called aqueous humor circulates. The eyeball, I said, is a hollow ball. It has to maintain a pressure to do its job. If the pressure is too low, the eye will shrivel, it'll collapse. It will not form a nice focusing organ. If the eye pressure is too high, that's when damage occurs to the optic nerve. So the fluid is continuously made, it's continually exiting, and in most cases of glaucoma, it's because the aqueous humor doesn't get out. It's because of a blockage of the outflow. And then the eye pressure increases and damage to the nerve occurs. Although increased pressure is it's kind of a nebulous concept, because about 1/3 to even maybe 1/2 of people with glaucoma have normal pressures anytime you measure them, or at most times that you measure them. So it's really a case of an eye that is sensitive to a lower pressure than usual. Yes, ma'am?
Does habitat have much of an effect on eyesight, like people who live in humid weather as opposed to?
No, not usually. People living in humid weather that have dry eyes are happier. But generally, no. So there's two main subtypes of glaucoma: open angle and closed angle. The Asian people are more subject to the closed angle. Blacks, Hispanics, and Caucasians more subject to open angle. Trabecular meshwork is where the fluid gets out, it gets clogged up, the aqueous doesn't get out, the pressure builds up, damage to the nerve occurs. No symptoms in the early stages. That's the important take-home message here. Closed angle, oh, you know what? Let me show that again. So here is the angle. Here is where the fluid is made. It has to travel in between the lens and the iris, and then it loops around and it goes out this little drainage channel here called the trabecular meshwork, and then out these little vessels, okay? So the aqueous is made here, it goes through the pupil and out here. In open angle glaucoma, that angle is open. In closed or narrow angle glaucoma, that angle is much narrower, and I think there will pop up a picture here that shows it. And you can see that the iris is being kind of slammed up against the outflow area. This typically is a very sudden process, but there are cases of chronic angle closure or intermittent angle closure too, where due to the state of the pupil dilation, the angle can close, it can open. So there are actually some kind of in between. There are people that we call mixed mechanism. They have both components, open angle and narrow angle. It's a medical emergency if you have an angle closure attack. It usually manifests itself by these symptoms: severe pain, nausea and vomiting, and fuzzy vision. Usually in one eye. Usually doesn't happen in both eyes. It'll happen usually in one eye. Risk factors, age, family history, it hugely runs in families. If you have a family member that is a parent or a sibling, you are probably at least 2 times and maybe 3 or 4 times more likely to get glaucoma. So elevated pressure. There are people running around, by the way, lots of them, that have high eye pressure and they never get glaucoma. Just like there are people that have high cholesterol that don't get coronary artery disease. So it's not simply the pressure. Nearsightedness or farsightedness, African, Hispanic, or Asian. Ancestry, diabetes is thought to be a risk factor, previous injury. And one thing we found, again, in the kind of the middle of the 2000 decade, thin corneas, it turns out, are much more prone to have glaucoma. It turns out to be a very big predictor of who will get glaucoma. So we measure corneal thickness now. So regular eye exams are really the best way to determine if you have glaucoma. We've sometimes done glaucoma screenings where we check the pressure. Checking the pressure alone is not a guarantee because, like I said, a lot of people have high pressures and don't have glaucoma, and a lot of people have normal pressures and have it. So you have to also measure, besides the tonometry, and there's me, I guess, getting ready to do a pressure measurement on somebody. The high tonometry reading is often one of the first signs. So we use a gonioscope to look at the angle. This is a view of the angle. You can see these kind of little scalloped things. Those are actually places where the iris has been inflamed and it's stuck up against the trabecular meshwork, probably in a person that's had an angle closure attack at some time. So that's the way we sort out narrow angle and open angle glaucoma. So we do dilation. We look at the optic nerve very carefully. This is a normal optic nerve. There's a little feature called a cup, and you can see this little paler area is the cup. Look at the cup here. It's huge. This nerve is just blown out from damage from glaucoma. And it could be, of course, anything in between. Visual field exams are done to test the peripheral vision. And then there are the treatment. The treatment is usually first drops. but always the treatment is aimed at lowering pressure. Drops are used, lasers are used, and surgical openings that are surgically created in the eye are used to all treat glaucoma. And also, in the narrow angle versus the open angle, the treatment's a little different. I think we will touch on that. So open angle medication, open angle glaucoma medication, usually eye drops. There are a few oral medicines, but most of the time it's eye drops. Most of the eye drops that we use now are once a day, which is real nice. We used to have pilocarpine, which you had to take 3 or 4 times a day. So surgery is done by laser application to the trabecular meshwork. We do have those lasers available to us here locally. And then there's surgical openings, trabeculectomy, which creates a new drainage channel. The goal in all of these is to lower pressure, to stabilize the process. So this shows a little flap being created. There's a little window that goes actually into the anterior chamber. That flap is laid back down. There's tissue that goes over it, and it forms kind of a little bubble or a hump of tissue that has lower resistance to the aqueous getting out, so the pressure goes down. There are also shunts, and there's a whole new type of surgery called MIGS, microincisional glaucoma surgery, which we often do in connection with cataract surgery. I do not do that yet. I'm probably going to gear up to do that this fall at the Academy meeting, though. So just the act of taking a cataract out is enough to lower pressure in some people. But if you need a little bit more pressure lowering, then you do one of these other little things like a stent that you put in that allows the pressure to get even better lowered than just doing the cataract surgery alone. So shunts or setons, plastic tubes, sometimes little metal tubes in the new MIGS surgery. So laser iridotomy is for narrow angle glaucoma. We do this little laser opening, and then the fluid has a way to get out. It doesn't have to go through the pupil. It has another way to get out, and it lessens the narrowness of the angle. Also, taking the cataract out lessens the narrowness of the angle. So if you catch it early and treat it, usually you can maintain good vision. If you get bad damage before it's caught, there's nothing you can do because it's central nervous, nothing you can do to bring it back. All you can do is lower the pressure and try to prevent it getting to get worse. And if you have bad damage, that progression of bad damage is a much easier for the disease process to go on and get going. It's like a snowball. So if you're at risk for glaucoma, you should really get your eyes checked more often. If you have a direct family member, if you are of African heritage, if you're of Hispanic heritage, your risks are greater. Here's the breakdown. If you're 20 to 29, once during that period, 30 to 39, twice during that period, 40 to 64, every 2 to 4 years, 65 years and older every 1 to 2 years, because that risk really does increase greatly as you get older. Yes, ma'am?
Is there ideal pressure readings that you
Oh,
want to?
that's a very good question. The normal pressure, normal quote pressure, is 10 to 21. But what's ideal for a person without glaucoma, anywhere in that normal range, may not be ideal for a person with advanced glaucoma. A person with really bad glaucoma may need a pressure down around 10 or 11 or 12. So, let's see, risk factors. People with risk factors, African descent or those with a family history of glaucoma, I would probably add Hispanic, should be seen every, a little bit, you bump up the schedule. Bump up the schedule. Okay, we're done. Yes, yes, sir.
I just got my eye exam a couple months ago. I got these, they call them floaters that float. Is there any way to get rid of that?
Oh, that's a good question.
Or what causes
Floaters are changes in the vitreous. Let's see. I don't know if I can go back to one of those. I guess I can't. Well, you remember our diagram, and I said that jelly that fills up the, the interior of the eye. That's where the vitreous is, and that's where floaters occur. And it is an aging change too. The vitreous, when you're young, it tends to be uniformly gel-like, and as you get older, it gets watery in places, and the little protein fibers that run through it and are normally invisible, they clump together, and that's what you're seeing. Their shadows being cast by that stuff in the vitreous. They drift around, yes. Now, if you get sudden vitreous floaters, you should get it checked, because the vitreous, when it undergoes the aging change, it'll detach. It'll pull away suddenly from the back of the eye. You may suddenly notice floaters that you had not seen before. If that happens, especially if it's accompanied by flashing lights, you should get that checked, because it can often be a symptom of a retinal tear. That's the commonest way for retinal detachments to occur.
Yeah, I haven't got that yet, but if you do that, do you do that?
I will treat a retinal tear if I can get to it easily. If I can't get to it easily, I'll ship them to the retina specialist. And I don't do it once it's detached. That's really, it used to be the general ophthalmologist did retinal detachments, but that has not been the case for a long time. Yeah.
But you just have to wait for them to go away. There's no getting rid of
The floaters? Well, three things happen. Your brain can kind of filter it out maybe, or they can kind of sink down out of the way of your vision, or they stay there and they never really go away. I've had a floater in the left eye here for years that bothers me, and you can surgically remove the vitreous, but again, you look at the risk to benefit ratio. If you surgically remove the vitreous, generally within 6 months to a year, you've got a cataract. So, you got to weigh the risks and the benefits. Yes, ma'am. No, actually, vitreous floaters often get a little bit more pronounced when cataract surgery is done, especially if the vitreous has not yet undergone its aging change. Cataract surgery can kind of cause the vitreous to... You got more after the cataract surgery? Yeah, more floaters, yeah. Yeah, that can happen. It may be that you're seeing them a little better, but it also can be because changes in the vitreous occur after the cataract surgery is done that make them more visible, that make the vitreous more consolidated. We don't usually do much for vitreous floaters. There have been people that have advocated doing the laser, like we do for the after cataract, to open a hole in the cloudy lens capsule. Retina specialists that I've talked to are a little nervous about that.
When they came out that they need the slits in the eye, because that having any distant vision was very...
I didn't quite catch the first part of what you said.
They operated on the eyes and made the slits so that it flattened things out and you could see.
Oh, radial keratotomy.
Yes.
I had that done myself. It was a terrible mistake. Yeah. Yeah, we don't do that anymore.
I know, but is there anything to do with, you can see those. My daughter sees hers. My daughter, it bothers her at night, the lights.
Yeah, because the cuts in the cornea, with the iris dilating, it depends on how big a central zone that they left uncut was. No, there's not much you can do. Once you make those cuts, they're there, and those scars are always there. That's why it's really not favored surgery anymore.